Okay, welcome everyone. And on this August 3rd at noon in at least London, Ontario, Canada time, I want to welcome you to our next edition of the Masterclass. And very honored today to be able to welcome Anne Gates to our Masterclass today to deliver what promises to be a fantastic lecture, which filled with practical tips for us in terms of making every contact count for physical activity. And so what I'd like to do, as we normally do before we begin, is just to, of course, welcome everyone, and then also start with a land acknowledgement. And so we acknowledge that this is sacred land upon which we're privileged to live and work. And we recognize the deep connection and the long-standing relationship between Indigenous peoples in the land of Southwest Ontario and of London. We acknowledge the Anishinaabe, Haudenosaunee, Lenapewauk, and Chinantan nations whose traditional lands we're gathered upon today, and we're deeply grateful to have the opportunity to be in this place. And so, as we always do with our master classes, we just have a few housekeeping items to mention. We've turned off the chat, and we'll be using the Q&A today. And this session is being recorded. And so after I speak, we'll have about 40 minutes or so from Anne, and then we'll have about 10 to 15 minutes of Q&A. And so one of the great features of this is that as people are typing in their questions, we'll save all those questions till the end. If there's one that you see that you like, you can like the question and essentially upvote it. So we prioritize those questions when we get to that section of the masterclass today. And I want to say as well that thank you to Dr. Eric Wong and Dr. Sadia Jan, who are scientific planning committee. So this masterclass was developed with input from them. And finally, I have the very distinct pleasure of introducing our speaker today. So we're thrilled to have Anne Gates join us. She's a clinical pharmacist passionate about exercise prescription for the prevention and treatment of chronic disease. She's the founder and CEO of Exercise Works, honorary associate professor at the University of Nottingham, and honorary visiting professor at Plymouth Martin University. Anne collaborates with international partners, including the World Heart Federation and European Union's Erasmus Plus program. And she works to improve the social determinants of health and promote health in low and middle income countries. Been a fantastic inspiration to me as well about physical activity prescription now for many years. So it is indeed a great honor to have you join us, Anne. And we're very, very grateful for your insights and expertise in this particular area. So I will turn off my video and turn it over to you. Thank you.
Thank you very much, Jane, for that lovely introduction. And also welcome everybody. As you can see, this is a photograph of a 9-year-old me next to a Canadian mounted policeman at your state parliament. And I feel it's almost like a complete circle for me. And I'm very honoured to be asked to speak with you today and to discuss physical activity. Mainly because this was actually a very pivotal time in my life for many reasons, but also because as a result of this visit to Canada, I was asked to write a project at the age of 10. And actually that project then enabled me to get a scholarship to my chosen school. And I probably wouldn't be sat here today had that project not won the hearts and minds of a secondary school that was a grammar school, and I probably wouldn't have studied pharmacy at Nottingham as a result of this. So it's a little bit of a surreal moment for me to show this, but I felt the warmth of the Canadians right from the very beginning of being in Canada. I was mainly in Ontario, and indeed I had my first camping trip ever in my life to Kingston on Lake Ontario, which was very memorable. So with that, I've also got some housekeeping to move on to, which is the disclosure of financial support. And here you can see the potential conflicts of interest from Dr. Jane Thornton and Dr. Eric Wong, who Jane has already kindly mentioned. But this programme received no commercial support, but is supported by the Department of Family Medicine. In terms of potential bias, the presentation will have potential bias managed by ensuring that any data and any recommendations are presented in a fair and balanced way, and in fact epitomise the World Health Organization, the WHO, information and recommendations. My disclosures are that I have received Erasmus, European Union, Horizon 2020 funding for our Vanguard project. But since then, I've actually now retired after COVID and have no other disclosures to mention. So welcome everybody, now that we've done some housekeeping, and today's presentation is all about making every contact count and every influence matter for physical activity and health as part of our roles as being a healthcare professional. And the reason why I'm starting with this particular slide is that physical activity advice and support is an excellent choice for all clinicians as a healthcare message as part of everyday consultations. So to give you some examples, to get one patient to give up smoking, doctors need to advise about 50 to 120 patients. However, to get one inactive patient to meet the recommended physical activity guidance as an adult, which is 150 minutes or 300 minutes if they've got concurrent chronic diseases, doctors need to advise just 12 patients. Now, obviously, I've worked in primary care for a long time, for over 10 years. I've worked in secondary care as well, and I've worked in a strategic level. And this is quite doable in day-to-day clinical practice, whether you're a primary care physician, a secondary care physician, or an allied health professional. And there's opportunities for us to collaborate in how we do this, and I'll go on to talk about that. But actually, physical activity has comparable benefits, and so there's no reason why we can't make every contact count for physical activity. And I'd just like to point out at the bottom of all my slides, you'll see all the references that are all hyperlinked should you want to access this information at a later date. The World Health Organization in 2020 produced a pivotal recommendations regarding physical activity. There is no mention of sport specifically, and it's much more about encouraging health practitioners to use a different type of language in engaging with their patients. So as you can see from this slide, on the left-hand side, doing some physical activity is better than doing none. They don't have to play racket sports. They don't have to run a marathon. And you can see here, there's a recommended range that was identified through research as the sweet spot for physical activity. And that range for adults is 150 minutes to 300 minutes, particularly 300 minutes in those with a non-communicable disease or chronic disease. And it's also an emphasis around moving high-risk sedentary behaviour, so sitting and physical inactivity, down towards a lower risk for non-communicable diseases, otherwise known as NCDs, non-communicable diseases. So taking somebody from this high-risk clinical picture to a low risk is what epitomises the World Health Organization's guidance. And the language that they use for us to use with patients is every move counts. So encouraging patients just to move more should be the gold standard within making every contact count. Now, I thought I'd clear up this because there's a lot of uncertainty from a lot of health professionals around risk management. And I just wanted to assure you that the World Health Organization also dealt with that in the 2020 guidance. And really, for any patient with unstable or uncontrolled signs and symptoms, so if somebody's got, an unstable angina, you don't want them, climbing a hill or running a marathon or, those sorts of things. And in those situations, with certain guidance, it's important to refer to special population advice. Now, obviously, a lot of patients have all these non-communicable diseases, and this is what was pivotal in this World Health Organization information, the risk of harm from moderate physical activity, even with these non-communicable diseases, is actually quite small compared to the risk and the adverse effects of inactivity and sedentary time. And they're quite clear in terms of increasing the incidence of non-communicable diseases and actually worsening people's health and mental well-being. So I just wanted to clear that out of the way really right from the very start and focus on this concept that primary care physicians, general practitioners, can contribute on a day-to-day basis. So 2 patients a day, can you encourage inactive patients or those with non-communicable diseases to be more active? And what I'm going to do is go through some of the language and some of the tips that we found helpful and are backed up with research, again, shown at the bottom of this slide. So encouraging patients to be physically active, to build strength, to improve their balance and minimize sedentary time is evidence-based practice. And how we go about that is really about how we engage in our patients on small bite-sized pieces of information. So for example, you know, if a patient is on aspirin 75 milligrams for cardiovascular disease or, you know, prevention of blood clots, we know that that's a very simple bite-sized piece of information that we can give to patients on why they need to take it. And actually physical activity or exercise is no different. So the language to be used is some is good, i.e. some physical activity is good, more is better. You know, to encourage patients to make a start today, it's never too late to exercise, and it never is too late to begin a physical activity program, that every minute counts, but also to start layering our conversations and highlighting some of the social and mental health benefits. And I've put some tips here that I'm not going to go into. You can have a look after the presentation. But basically, again, using that aspirin 75 milligrams analogy, you know, I'd like you to start some strength building exercises to help keep your muscles and bones and joints strong. And we know that this is really important. You know, healthcare professionals are credible sources of information. So as primary care physicians, you're in a unique position to interface with patients within your community, you know, as part of everyday clinical practice. We know patients trust your advice. So this is really important to get right. I mean, for example, in the UK, the trust factor with our health professionals is 90%. I have to say with our politicians, it's 19%. So you can see within society's values that as healthcare professionals, this is important work for you to be contributing into everyday practice. And to talk about encouraging more movement and coordination. You know, this isn't about them joining a sports club necessarily or running a marathon or things. It's about everyday activity as a starter, as a conduit, as an easy win. But also, and this is very key, and I'm going to talk about this in more depth, is minimizing this sedentary time. And for the first time in the physical activity guidance across countries, nations, and the world, was about this minimizing sitting and inactivity. And that's quite important because it's linked to increases in obesity and obviously endocrine and cardiovascular disorders. So again, there was a change in the guidance that's also talking about mental health. You cannot distinguish between the mind and the body in terms of the benefits of physical activity. So there was a much greater partnership in the language for helping patients to access better mental health well-being. For example, here highlighting the social and mental health benefits of physical activity, doing things that make people happy, not something that they hated at school or, you know, they feel obliged to do, you know, because it's the Canadian national sport or something like that, but being able to do something that fits for them, that works within their abilities and their environments. And little things like improving balance with Tai Chi or yoga, or building strength, you know, in ways that work for them with community outdoor gyms or carrying shopping or, you know, doing gardening jobs. It's incredibly important. But again, I want to bring your attention to this minimizing sitting and inactivity as a key component. Now, we're all guilty of sedentary behaviour, and indeed 81% of all adolescents are classed as sedentary, which is really shocking for the future health of our nations. But what they wanted us to do as practitioners is to talk about limit your sitting, limit your inactivity in whatever your day-to-day jobs and lifestyles are, and replace sedentary time with just a little bit more of physical activity. So these are important concepts in terms of exercise prescription. So talk about, you know, with patients, you know, can you limit your sitting? Can you, you know, can you do extra jobs? Can you, you know, around the house? Can you, you know, can you walk rather than taking the car or getting a bus or other forms, you know, for various activities? So to cut down and limit that sedentary behaviour, and can you replace that inactivity by doing something of moderate or vigorous activity? So right across the life course, whether you're looking at paediatric patients or children, young adults, right the way through to older adults and people with disabilities or living with chronic disease conditions, it's important that we have this concept. And you can see here, the WHO theme is consistent. So we need to be mirroring that in our day-to-day practice. So talk about limit sitting, replacing inactive moments during the day on a regular basis. So I'm just going to show through with pregnancy, with adults and older adults with chronic conditions, limit, replace. So this is an opportunity for you to start practicing these conversations and this language in terms of exercise prescription in day-to-day practice. And one of the fundamentals is the ask, assess and advise format, really, just to hang your consultation around some things. So opening up a conversation saying, you know, one of the things that we can do in your disease condition or living with X, Y and Z is you know, and helping you to feel healthier and regain mental wellness is obviously to be active. You know, can I ask how physically active are you? And you can then start to get some idea of the levels of physical inactivity and sedentary behaviour within your patient populations and in your communities. And I think that that's quite positive. You know, for somebody like myself, you know, I was really sporty all through my life. You know, I then went into exercise medicine, even as a pharmacist. So, you know, I love my medicines. I love the drugs to, you know, for patients to help get them better and treatment options. But actually being physically active is something that has lots and lots of barriers and also, you know, negative connotations with patients that we need to be able to address. And I'm going to talk about that in a minute or two. But, you know, if somebody's regularly active, you know, well done, keep it up. If they're not, this language of some is good, more is better, let me help you, let me refer you or provide support resources, which Jane Thornton has alluded to, Dr. Thornton's alluded to, is so important. And just in, you know, very, very short, brief intervention, you know, I'm not talking about GPs having a PhD in motivational interviewing, because that's not what it's about. It's about that connection with your patients and understanding their backgrounds and helping patients to understand how physical activity can help them manage some symptoms, help them manage their day-to-day life and live, you know, live more active lives. So it's important to explore this and start to set some achievable goals with them that you can then follow up when you see them next, either for repeat medicine reviews or as part of their clinic reviews. But also to start to embed this within your clinic practice. So clinic nurses, clinic pharmacists, clinic physiotherapists, kinesiologists, I don't care what profession you're in, if you're working with patients, then there ought to be a consolidated shared purpose to helping patients to access physical activity. And I have to say, we do make it very difficult, which is why we've got such bad levels of physical inactivity, not only in Canada, but also across the world. And I know that other speakers will allude to that. But my passion is non-communicable diseases, specifically cancer and cardiovascular disease, but also the immobility and potential disability that sometimes goes with those. And I think that that's a special opportunity to highlight some of the barriers and help patients overcome those barriers. So, such as pain before and during physical activity. You know, in some of the cancer patients, we used to give pain relieving medicines if we needed to mobilize them or if we needed to do that. That's all part of a holistic care program in terms of rehabilitation and support when they feel tired from chemotherapy, how to manage that, and also how to manage fatigue and breathlessness and lack of motivation. And actually, there's a lot of research that has been explored on this, and also just the feeling embarrassed. You know, a lot of female patients will feel very uncomfortable in gym environments or environments where they don't feel safe necessarily, or they feel threatened in lots of ways. So it's important for us to know those situations and scenarios for each individual patient and reassure, support them, and build up their confidence in some choices to be, more physically active, such as wheelchair, dance, and various other things. And, you know, as part of my remit in this presentation, I was asked to explore some of these patient barriers, some of the responses that you get when you raise physical activity. And this isn't a one-off, one-win situation. This is slowly helping patients and moving them, and a paradigm shift in the conversations that you have. So yes, exercise can be hard work, but actually, you know, there's language which we can use, and narrative that they can start slowly and build up. It's not something that they have to go out and do immediately. They can just make small changes, and you can start to monitor those small changes as well. You know, a common factor is not having time, and I'll come on to GPs not having time to discuss these issues later. But patients often say, I don't have time. I'm running 2 jobs. I've got a family of 3. I'm also looking after an elderly relative. And there are quick fixes and a lot of support out in communities that help to address some of those things. So maybe parking the car 5 minutes away from work, or 10 minutes, and allowing an extra few minutes walking can significantly improve somebody's cardiovascular health. And so learning to address some of these barriers is, to me, part of the consult. It's like knowing the contraindications of a medicine. It's like knowing what side effects and dose titrations you need to know. So I would suggest that all primary care physicians and secondary care physicians need to have some of this information as part of their armamentarium within the Making Every Contact Count. Being too tired, I don't like exercise. But actually, when you start to agree some goals and you start to monitor progress, and you consider simple things like walking more or cycling, or referring to specialist clinics, which I'll come on to, is extremely important. And reaffirming the key health messages. Some exercise is good, more is better. Limit your sitting, replace it with more physical activity. Signpost the patient on why they should sit less. But also this paradigm shift in moving from a one-off consult to actually providing continuing care to your patients in primary care. And actually multiple nudges by multiple healthcare professionals. So the diabetes nurse, maybe the cardiac rehabilitation nurses or teams, is much more likely to enable your patient to see the benefits of physical activity for the health and mental health as well. So in summary, for this part of Making Every Contact Count, there's some key issues. One is advising patients who've had a recent cardiovascular event to local cardiac rehabilitation services. I say that because there's huge inequities of access. So in the UK, a male who's had a cardiac event, 79% access cardiac rehabilitation. For women, it's 29%. So you've got 79% compared to 21%. What's going on there? Why aren't we providing proper rehabilitation care and access to care for women after a cardiac event? Doesn't occur. I don't know what the data is in Canada, but I'm sure it's going to be very similar. Also advising patients for very specific referrals, such as pulmonary rehabilitation for chronic obstructive pulmonary disease, advising patients with MSK rehabilitation, which is obviously Dr. Jane Thornton's and her clinic's, focus as well, but also looking at COVID-19 rehabilitation. We've got a lot of long COVID in Britain. I'm sure you have in Canada as well, all around the world. And obviously exercise can exacerbate post-exertional malaise. So again, long COVID clinics is where the way we're moving to enable patients with long COVID to access meaningful activity for themselves, but also to support families to access established rehabilitation protocols. So the next part is just showing some of the work that Jane and Naomi Abayomi, who is a fantastic medical student from the University of Ottawa, has just highlighted, and you can see the link to some of these resources. But I'm basically saying there are resources out there. So apart from this presentation and me asking you to make every contact count, there's guidance out there. We know about specific language to be used. We know about inclusive language, about the importance of healthcare professionals, linking these to physical activity clinical leads and safety tips, but also signposting to the plethora of resources that are available in Canada, but also using the exercise sheets that Jane and I have developed with Naomi. And here you can see these are hot off the press. They're on Dr. Jane Thornton's website, My Active Ingredient. And again, we've broken this down. So in conjunction with a consultation, you are now able to provide the patient with a link, or even print these off within your clinic environment for very specific disease conditions. So in this one, this is exercising with breast cancer. Again, using the WHO specific language. So we're strengthening that systematic strategic approach. So every move counts, how to get started, what warm up and cool down they might need, being active. Some is good, more is better. So again, your patients can take these away and have confidence. And also we've included some very helpful across Canada resources, not just specific to Ontario, which again is very good, but also it gives them some tips on what type of exercise. So we sort of moved away from the fit exercise prescription, which is frequency, intensity, time and type, but we've given much more everyday physical activity as part of the recommendations, because that's where the evidence base is. It's about getting patients to move more. Now, this ends the Making Every Contact Count, and I'm going to talk now about quite a challenging aspect to this presentation. And that's because I passionately believe that you are all leaders and you are all able to affect impactful change on behalf of your communities. Your voices are needed, your influence is needed. And that's because certainly the UK is unlikely to reduce physical inactivity by 10% in 2025. So the UK isn't going to make that deadline, and certainly not the deadline of reducing physical inactivity across the life course by 2030. And so this is what every single nation in the world has signed up to do. So from my perspective, and as I said, I used to be a strategist and a planner of services and service development, we need to start embedding now how we achieve those goals. And part of it is something called change agency, which I'm going to talk about, and building capacity within our system and general practice. But it relies on the competence, capability, and confidence of making every contact count for physical activity. That then allows you to give this voice, this leadership, this, well, why aren't cycle lanes safe in our cities? Why don't we have safer green spaces for women and children to exercise in? What system change can I implement? And part of my passion is about making sure that that's embedded in undergraduate education, so we hit the floor running, but also, like we're doing postgraduate education now, that you take on the responsibilities of influencing your clinical practice, your clinic's environment and how you address inactivity, and also linking in with community partners and other areas, and forging stronger networks and links for the benefit of the patient population. So change starts with you. Everybody's a change agent, and today I want to sow those seeds and disperse those concepts of, not taking a long time about it. I have a particular thing about PhDs, because by the time something is developed and researched and then put into practice, you're looking at 15, 20 years, maybe down the line. And that's not actually, we haven't got that luxury of time in terms of changing our population. So change agency is about you making the change. It can be small, it can be big, depending on your capabilities. It can be you or working collectively and collaboratively. But it's something that everybody can do. You're only as good as the standard you walk past. And everybody and anybody can be a change agent. It could be the reception staff. It could be a cleaner. It could be, anybody within the clinic that has a good idea that you can take forward to help promote physical activity within the clinic. And a lot of this requires the concept of old power, very transactional, very traditional power and hierarchies, and moving those over to, a new power, a new way of connecting, a new way of doing business, a new way of looking at societal problems, and looking at relationships and sharing some of those responsibilities. So the rest of the presentation is what I call around change agency. And I don't think you can have making every contact count and influencing those, those 12 patients, the numbers needed to treat that I showed you right at the beginning. It's about sustaining that practice and elevating it and exploring it in other ways by making connections, growing your networks and helping relationships. So, system change does not happen overnight. It is always cultural. So you can have the best policies and procedures, but actually we are hardwired as human beings, and especially patients, to try and outfix some of those policies. So collective agency works across, groups of people who are passionate. It might be a general practitioner with a special interest in cardiovascular medicine or diabetes, type 2 diabetes. But it might be also looking at adolescents and linking them into potential physical activity and sporting clubs and social connections that can help promote physical activity and reduce sedentary behaviour. So this is very much a different way of working that I'd love you to embrace today. And I realise it's challenging, but working more and thinking more is, as a practice, as a clinic, can we have 30, 60, 90-day change cycles? So at the end of 6 months, we've taken something that maybe was a bit clunky. Maybe our consultation style didn't allow for physical activity advice, but could we put that better in the waiting room? Could we give better links to resources to our patients? Could we maybe get our medical students to clerk for physical inactivity as part of their placements? Are there ways in which we could work with a local volunteer or charity organisation that could do that? So looking at different ways and doing things quicker. because we're never going to meet that WHO guideline if we continue doing what we've always done. So this is about a change agency program that has been instituted within the National Health Service. And in addition to making every contact count, so mentioning physical activity in all consultations, and encouraging older patients that are at risk of sarcopenia, muscle wastage, and with health conditions to avoid sitting, because that is a killer, but also to make it achievable, things that they can do in their everyday life, requires a transformational shift in the way we work as clinicians. So thinking about your clinic setting and how you promote physical activity is one of the main takeaways from this presentation. Looking at social prescribing pathways and ensuring that everything from looking and preparing a patient with complex individual needs and moving them towards a path is something that happens well in general practice. But that wider consolidation of helping patients learn new skills and access different opportunities to help, maintain employment, because immobility and disability is on a trajectory at a very high level at the moment, but also activities that are like the social glue within our communities is important to understand as general practitioners. So today, I'm going to sort of stop talking to some extent and go over the social determinants of health very quickly and understanding those, looking at the differences between equality and equity and the issues associated with those. So if we have a clinic that just gives a one-size-fits-all, which is the top half of this, apologies, sorry. Can you...
Everything's visible. Yeah.
Oh, is it? Oh, right. Okay. Sorry, yeah. I went on to something else. But also looking at equity as well is incredibly important. So in summary, this influence is really important. And the World Health Organization has already done the work for this. So this is some homework afterwards on looking at the Let's Be Active, Everyone, Everywhere, Every Day philosophy. There's 4 key components. One is creating active societies, creating active environments, creating active people, and creating active systems, and linking into that change agency. You could do one of these a month. They're small projects. These aren't big ones. If you want to take on a big project, that's fine. But, be able to complete, be able to get impact what you're doing. And start with promoting this concept of physical well-being, helps mental well-being, helps make individual development so much stronger and so much more accessible for patients and their families, their communities and their carers. But to think about what you could change in terms of what examples of social prescribing are available, how do patients and communities access these, thinking about other global physical activities and starting some of that networking that can help strengthen your clinical practice. And maybe, some of you might be interested in doing some research on this. Inequities exist. So we have challenges in the United Kingdom. So this north-south divide, I absolutely positively hate. I've hated it throughout my whole 40 years of career, of my career. So here is a north-south divide for the have-nots, which is in the north of the country, and the haves economically in the south of the country. So you can see that if you live in the south of the country, 60% of the population easily accesses 150 minutes a week, whereas if you're in the north of the country, you're not. And we know that the impact that has on physical inactivity. So what inequities do you have where you live and practice? What inequities are in your regions? And, Canada's a big place. I think you've got 10 provinces and various territories. What are the differences between the provinces? Who's doing it well? Who's not doing it so well? Because those social determinants are maybe playing and will never fix physical inactivity unless we link it into the social determinants of health. Some various ethnic groups, and I heard, your disclosures about the land and everything else. It's very important that one size doesn't fit all. We need to be culturally sensitive and appropriate and help certain communities to engage in physical activity that's bespoke to their needs. And, you know, it is quite shocking when you start to do comparisons of physical activity with ethnicity. And this is information from Public Health England. So they did some of this work. And, you know, it's very painful because a lot of these patients won't be accessing cardiac rehab, pulmonary rehabilitation, not even accessing green spaces safely within their own communities. So there's a great video here that I won't show today, but for you to have a look at a later date. So it's important for you to think about exercise advice for different populations, and particularly with intellectual disabilities, which so often get you know, fallen off the horizon. And I'm a great believer in making sure that exercise advice is for everybody to access. And so looking at some of the best practice, you know, do you have intellectual disability bespoke services? Are you able to signpost patients to support? What local groups and local communities can offer her some help? And I just want to sort of give you a flavour as I finish up here. This is doable by joining together, and this is a group of physiotherapists from all around the world, sharing and caring what's happening within their countries, and joining together and understanding some of this complexity that is in these are mainly primary care physiotherapists, of some of the issues of patients exercising more, this every move counts philosophy. And so, you know, I acknowledge that there's a lack of knowledge within healthcare professionals. There is a lack of time. It might be a lack of confidence and competent capabilities, but that's all about education and ongoing support. These are things that we can easily and have the competencies to get around. And actually exercise works from cradle to grave, whatever chronic disease patients might have. So in terms of the sound bites for Canada, and I'm just about to finish now before I run out of time, it's very important to make every contact count. So use the ask, assess, advise format, or devise something that works for you. Resources are widely available. You are not alone. There are lots of support for practitioners and patients and their families and carers to understand more about how to exercise well and safely. Stick to simple, consistent language. I think I mentioned sport right at the beginning. Sport isn't necessarily an enabler to patients that have been active for long periods of time, or maybe part of their career. So think about ways in which you can engage. So there's a famous research project in Scotland called Walking to Football Matches, which looked at a group of men for weight loss, and rather than them getting transport or taking cars to football matches, they walked, and they walked as a community. And so that improved the men's health. They were doing something that they found enjoyable, so it added that social cohesion and interactiveness. So there's lots of ways around this. Avoid exclusion language, you know, and the gym narrative, you know, is very difficult for a lot of people in Britain to access or even feel with home gyms, you know, that it's something that they're able to sustain in everyday practice. But it's embracing this concept of change agency. So I think it was Mahatma Gandhi said, you know, you are the change. You have to change for us to deliver a more active, healthy, happier nation. We have to change some of our approaches because they're not working and they haven't worked in the past. And, you know, I actually think that change agency is easy with help and this collaborative approach and this shared approach and shared purpose. But my challenge for you today is to think about these. Maybe choose a bite-size intervention that you can monitor and provide influence over. And again, these are included. So Think about what physical activity campaigns have been successful locally. Expand your knowledge of implementation. So this isn't about necessarily research. This is about the doing. This is about making the change. What did it feel like? Not everybody is comfortable with physical activity and change agency. So learn and share from others. What were the cultural and strategic enablers to this change? And how is societal impact valued and measured? You know, what are going to be the endpoints of this? How are you going to measure your patient satisfaction and patient changes? But also look at what others have achieved. I mean, Jane and I worked on the Movement for Movement resources for undergraduates. You can follow the Movement for Movement hashtag within, it's embedded, the link is embedded within the presentation, but also start to link with more provincial, national and international networks to help patients be more active. To get to this situation and relationships that I've built globally and nationally, I've had an absolute shed load of help from people. And I'd just like to say from the bottom of my heart, reflecting on that 9-year-old who went to Canada for 6 weeks, there's a lot of people that have helped me in my career, and I'd like to thank them wholeheartedly for all their support in developing our Erasmus Plus project for the European Union. But most of all, I'd like to thank the patients and families and carers who taught me right from the start of my career on those teachable moments, how language influences a patient, how language can influence people's strategic decisions, and how to support change agency. But most of all, I'd like to come full circle and thank the Canadians for their hospitality when I went over to Canada, but also to thank you for inviting me to speak today on physical activity and making every contact count. And special thanks to Dr. Jane Thornton and her team today. Thank you.
Thank you so much, Anne. It's wonderful. And you hit on so many important points. And I think that we need to hear not just in primary care practice, but certainly across healthcare provider fields. Thank you so much for just the inspiration, because I think what gets us a lot in terms of the barriers is that we just don't know, can we actually do this? Can we affect change? And I think you've really convinced us of that aspect of change agency being so important and so critical. And just starting to do the work and understanding that from the patient's perspective, it's not only critical, but also desired. And so it's really something that we can start incorporating into everyday practice. So thank you so much for highlighting all of those for us today. I have a couple of questions in the Q&A, which I'll field and ask you, and had some other questions as well. One of our attendees, Lisa Dow, mentioned she's a physiotherapist, and she said, "This is so great," many exclamation marks, and that she also runs 2 virtual low-cost programs for chronic lung disease and another one for functional fitness. So those are great. Thanks for including those links. It reminds me, and then she mentions as well that she also talks about if exercise were easy, that everyone would do it, but that it can be very rewarding for people. It reminds me as well in terms of something, and you did mention it in one of your final slides there, about the community of practice. And I just wondering if you can highlight that in the sense of, so we have physiotherapists, you yourself as a pharmacist, we have GPs on the call as well, and from a number of different disciplines. And just wondering if you could touch on the importance of the community of practice and how we can work together. You have touched on it a little bit, but in terms of how critical it may be, or even how we start, how do you start to form that team? Who do you look to in order to get this village to support your patients becoming more physically active?
Well, I think that's about this change agency, because leadership starts with us all. So I think giving the voice of confidence in learning about exercise prescription is important. But you've got colleagues, that have mentioned about the importance of pulmonary rehab and local really good nuggets of support that maybe not every general practitioner knows about. So in terms of a community of practice, again, this is part of this shared purpose, working very, very differently. So leaving the hierarchies, I'm talking about medical and clinical hierarchies, at the door, leaving pre-existing silos of clinical practice, and being able to come together and say, hey, you know, I don't know, London, Ontario has a really high, sorry, that's your patch, I think, Jane, so sorry to highlight that, but it just came to me. London, Ontario has a really bad physical activity. You know, patients with chronic obstructive pulmonary disease don't actually access, you know, what are good standards of practice. How do we encourage more diversity and inclusivity? And maybe like having, you know, a huddle. I don't know if that translates to Canadian practice, but, you know, getting a group of people to meet together, maybe getting a group of GP practices to come to say, look, you know, physical inactivity in our local adolescents is really, really bad. You know, it links on to other, you know, with other social determinants. How do we consolidate and link up our practice by talking around activity? But a community of practice works very differently. So that requires each individual to contribute. And it requires the community of practice to honour and recognise those contributions, no matter how small. Right. So if you remember, I mentioned cleaning personnel. Mm-hmm. And, you know, making sure that an area is, you know, clean and accessible for patients to maybe do walk to the clinic or not take, you know, take the stairs. You know, I once did a visit to an international hospital and I said, oh, I'll take the stairs. Well, clearly it hadn't been cleaned because there were cockroaches on the stairs. I mean, I was a little bit, it's like, you know, we don't do cockroaches that often in Britain, thank God. But actually, you know, if I felt uncomfortable, what will patients feel in taking the stairs? So those sound bites have to match what's happening within our clinics and our hospital environments. You can't take the stairs if patients are going to feel uncomfortable. So it's about bringing everybody on board and saying, how do we create an environment where physical activity becomes so much easier? How do we talk with each other? And that's the concept of a community of practice. It breaks down the barriers. It recognizes that everybody's input is really important.
Excellent. Thank you for that. We have another question. Well, it's more of a question and a comment. Superb slides. As we always know, coming from Anne, you have superb slides. Is a PDF of the slides available so that they can share this presentation with colleagues?
Yes. So all the information is available. Thanks very much to the hard work of Jane and her team, and particularly Kirsten. But also to be available. But also, I've included this signpost to these exercise sheets that we'd really love feedback and support from. So you can download these from Dr. Thornton's site, My Active Ingredient. I think they're also going to be on Chasm as well. But these are really important because you not only can you print these out in the clinic, so you'll have the PDF. And actually, Jane, I'm quite happy for you to, for those that want it, to share the movement for movement resources for undergraduates, because actually the information works just as well for postgraduate information. So, you know, I'm quite happy for a link to be shared with the clinicians, as long as accreditation to us is due, for them to have access to that, because these are international slides. So although my slide set wasn't Canada specific, we ask the individuals using them to incorporate their own information, their own data, to make it resonant with, you know, with Canadians and things like that. So, so yes, PDF of the presentation is available. The exercise sheets are freely available and downloadable for both health practitioners and patients and their carers. So you can print them off the clinics or whatever if you do a specific clinic. And we'll give movement for movement resources open access somehow or other, Jane.
Yeah, we can figure that out. Absolutely.
We can figure that out. That's just technical.
Yeah, no, it's wonderful. And then someone did ask about the site. So and Kristen's put it in the chat, but it's myactiveingredient.org. But Anne, tremendous amount of work that it's really a labor of love, the tremendous amount of work that you've put into those resources and the content of so many different resources. What is it, over 50 or something along those lines? It's exceptional.
The exercise sheets, the exercise sheets is 52. So they cover all the main chronic diseases. And I'll just say as a soundbite, the most downloaded exercise sheet was for stoma care. So that flags up to me that there's this big dearth of information on helping people who may have gone through, GI surgery and have stoma care on how to access physical activity with a stoma and how to manage that. So, these are some very, very practical points for patients, and they're the bread and butter of general practice.
Absolutely. And so I will finish off with one question, and then if there's anything else you'd like to add, I also want to, before I say that, preempt it with a comment from Claire Drummy, who's another guest. It just says, excellent presentation, so motivating. Thanks so much, Anne. So yet another comment. So excellent. I come back to this motivation as something that's inspired me for many, many years as we've collaborated over the years, Anne, and as I've learned from you, is that your passion and desire to provide these resources, free online access to everyone. And I'm just wondering if you could maybe touch on, as we finish up, why this was so important to you, and how your kind of motivation and inspiration on doing that, and how you see kind of the next steps for those wishing to contribute to this space, how they might go about that.
I felt as a pharmacist, and I was a clinical pharmacist, not only in hospital, but primary care. I'm used to patients having patient information leaflets. I'm used to communicating to patients about how best to take their medicines, but also delivering services that meet their needs. And I went to an exercises medicine conference back in 2010, and it blew me away. And to be honest, it was a cathartic moment in my career, because yes, I was a clinical pharmacist. I love my drugs. I love medicine. I love what it does. I love how to help patients. But actually, when it came to exercise, it was becoming really complicated by the sport narrative. And I actually felt, well, what we need is like the label, how to exercise safely, how to exercise within your needs. And so the thought processes came to me, and I have, I'm quite creative in some of my really way out thinking, but I'm also follow through. I'm a completer finisher. So it came about that I realized that actually this needs to be taught at undergraduates right across medical school, right across allied health professionals, even physiotherapists. My son's a senior physiotherapist. They're not necessarily taught about engaging patients. Yes, if they've got, anterior cruciate ligament exercises, but when it comes to day-to-day engagement, that's a bit of a challenge. And it's a challenge if it's outside an MSK remit. Like the person talking about pulmonary rehab. If you've got somebody who's got COPD and an MSK patient, and is an MSK patient, it's how you marry those two. And so that's why the Movement for Move resources came about. And again, there's 22 slide sets, and they're classed as essential and desirable learning. So it's a pick and mix really for what you want to know about. But they're there, and they are evidence-based and proved until 2026.
Wonderful. Thank you so much. So in our remaining minute, I again want to thank you so much, Anne, for coming and sharing your insights, but also the amount of work and passion that you've dedicated to this project is it's exceptional, really. And so just for sharing some of your insights, but also passing along that enthusiasm and passion. We've already gotten great responses on this in terms of how applicable and how impactful this presentation is. So I really do thank you for that, and your constant inspiration and support. And together, you know, I'm just always continually looking forward to seeing what else comes next, in the sense of this free
retiring, yes.
Yeah, no, never. So I want to just thank our attendees as well as we wrap up. It's just at the hour now. Just for the last 30 seconds, just to say that you will be sent an email containing a link to the participant evaluation survey tomorrow. So please take the time to complete that survey, and then that's where you can indicate if you need a certificate of participation. And then you can claim your CME credits if you'd like. And then if you'd like to email us with any questions or concerns, research coordinator Kristen's email was sent in the registration, and it's also inputted in the chat. You can also and request a certificate all through those links as well. So anyway, again, thanks to everyone for your attention and for your participation. Thanks for the great questions and the links. We're always happy to add more and hear from people. And again, thanks, Anne, for a superb talk, and looking forward to seeing you again.
Thank you. It's an honor, Canada. And I'd just like to say thank you as a 9-year-old child, because had I not been to Canada, I wouldn't have got into school, I wouldn't have gone into university, and I wouldn't be sat here. So it's thanks to Canada.
That's great. You're welcome from Canada, on behalf of Canada. Okay, thanks so much.
Thank you. Bye-bye. Bye-bye.
Bye.